Okay, welcome everybody to this Adrenal Masterclass. And I'm going to start. I want you all to answer the question that I'm going to pose. If you've got your phones out on Menti, you'll see the question. I'm going to talk about AVS, adrenal venous sampling. So I'll just mention a typical case of hypertension and hyperkalemia. And you've got a young person with hypertension and hyperkalemia, then you've got to look for secondary causes. Okay, and he's young, and if you can treat a secondary cause, that's great. And just to quickly remind you that the JGA axis controls this through measuring renin, which stimulates production of angiotensin 2, which does two things. It constricts the efferent arteriole, but importantly, it is the stimulus for the release of aldosterone, which therefore maintains your blood pressure when it falls. Now, if instead of a normal adrenal, you have an adrenal adenoma that's making aldosterone, it'll be high. And that high aldosterone will cause blood pressure to rise by retaining sodium, etc. And that hypertension will suppress the renin. So there's the primary test for Conn syndrome. You measure the aldosterone-renin ratio. If it's high aldosterone with a low renin, then it's obviously independent tumor making aldosterone. Importantly, we use beta blockers quite a lot, and beta blockers prevent the release of renin, and therefore you can only do this test off a beta blocker. Okay, it's a screening test. All the other things, you can leave them on for the screen, but you must do them off a beta blocker. Otherwise, you'll have a zero renin, and division by zero gives you infinity. So as you know, this is typical Conn syndrome with hypertension, hyperkalemia, high aldosterone, low renin, okay? And some people, as first described, they're young, have a Conn adenoma, but older people have a risk of bilateral adrenal hyperplasia. And so the question you're being asked is, which is more common, an APA, that's a tumor that you can see, or is it just bilateral adrenal hyper, nodular biadrenals, both making aldosterone? And the second question is, which is more common? Okay, adenoma, or, and let's see what you will vote. Okay, correct for most of you. Okay, but 27 you think that an adenoma is more common. That's wrong. Okay, bilateral adrenal disease is by a long way the commonest cause of Conn syndrome. Okay, and here's some evidence looking at screening these people. So if you take all people with hypertension, you have got 90-odd% with just essential hypertension, and about 6% who've got Conn syndrome. And within that, 2/3 have got bilateral nodular hyperplasia. That means surgery is not good for them. This is I'm giving you now the gold standard original textbook teaching, because things are going to change, as you're going to hear in the next talk. But essentially, typically, adenoma is only a quarter of them, okay? And 2/3 are bilateral. And the teaching up to now has been, if it's bilateral, they need medical treatment, okay? Now, the thing is, if you start screening hypertension, you're going to find more mild disease, more normal potassium, and it is correct to say that some CONS patients are normokalemic. But within that group, there's going to be more bilateral disease than a CONS adenoma, and some people argue there's no point looking for those people because it's bilateral, the treatment's going medical anyway. Why not just give them spironolactone and miss out all this time-wasting nonsense, okay? So here's the guidelines, okay, that you've seen before, and remind you, if they are at risk of primary aldosteronism, you do the ratio, and if it looks likely, you confirm the diagnosis, and if the patient wants an operation, you then take it further. If they don't want an operation, I think you don't even need an adrenal CT, because why do you want to do a CT if it's not going to be an operation? So you do the CT if surgery is desired. So I think that's in the wrong place. I think you should ask them, would you want an operation? If they say, I'll consider it, then you say, well, let's do a CT. If they say, no, I'm never having an operation, you can then give them spironolactone, okay? It'll work. Even after you've done the test, you then need to see if it's unilateral or bilateral with an AVS, okay? And if it's bilateral, you give them medical treatment anyway. The only ones who need surgery, which should be laparoscopic nowadays, is if they've got unilateral disease, okay? So quite a lot of patients will go down the medical treatment route, but unilateral patients they're the ones who need surgery. Now, you're going to hear in the future from places like Barts and Cambridge that instead of going for a full adrenalectomy, we might be able to do various types of ablation. This is research, but at the moment, we're going for surgery for most patients. So back to this patient, hypertensive, he's actually on potassium and he's got a high ratio, I'll show you there, Aldo 500, suppressed reading off a beta blocker. So this confirms CONNS syndrome. And here's the rules. If it's more than 2,000 ratio, it makes it likely. If it's less than 850, it's unlikely. But there is always a false positive and a false negative rate. And so we go on to do confirmatory testing. We do a serum suppression test. And the guideline says if your cortisol remains, so if your aldosterone remains above 280, you're likely to have it. There's a gray area between 140 and 280. Less than 140, you probably don't have it. And if it's in between, then you look at the whole situation. Okay, but this is not even gray. This is an obvious case of CONNS syndrome. And it's confirmed. Okay, so you ask the patient, do you want an operation? I would say don't immediately if you don't want an operation because we know it's CONNS syndrome. It could be unilateral and it could be bilateral. And both of them can be managed medically, but perhaps there's some thoughts that we should take out a unilateral lesion. So we're going to do, right? Supposing you do the CT scan and you find a 1.7 centimeter left adrenal tumor. And your CT scan shows a nice normal right adrenal, so definitely left visible, fairly good size, 1.7 centimeters lesion. Do you want to do an angiography and venous sampling? Do you want to say, look, let's take out that tumor that we can see, or do you want to just start medical therapy? So I'll let you all vote. 3 seconds, choose on your phones, 1, okay. And okay, so most of you follow the guidelines which say we need to prove that the right adrenal is not also making it. So just to be clear, AVS is not to say which side it's on. AVS is to say it's not bilateral. Okay, that's its purpose. Okay, it's not to say it's on the right or left. Okay, because if it's on the left, you need to know the right is suppressed. That is the real purpose of AVS. So we do AVS. Okay, 8 of you want to start medical therapy, and 22 of you not unreasonably think it's so likely to be that lesion. It's so obvious to see, and the other side looks normal on a good quality CT. So a lot of centers are now saying, look, under certain criteria, like very young people, maybe under 35, for example, you don't need to be in a sampling because it's so likely to be unilateral if you have all the right things, very low potassium and so on, right? But if you really want to not get it wrong, then venous sampling is helpful. Now, a bit about venous sampling, you cannulate both groins and you thread the lines into the left. There's a 1.7 centimeter lump, and the other side you cannulate the other adrenal, and then you take blood from them and you measure various things. Okay, you want to make sure that it's not bilateral, which is the main reason to do the angiogram. So here is a baseline set of results. First of all, you look at the cortisol. Okay, in the IVC, it's about 448. In the right adrenal, it's more than 5 times higher, 2,000. So we're definitely in, okay, the right adrenal, and left adrenal even better. So we're pretty sure that both sides have been correctly cannulated. Good. You then look at aldosterone and you work out the AC ratio. That's 50,000 divided by 7,000 is 6.34. So that's higher than the IVC. But what really matters is the other side. And the other side, the ratio is lower than half, less than half of the IVC. Okay, so that tells you the right suppressor. Shall we go for a left, a right, or start medical therapy and vote now? And you all voted for yes, left adrenalectomy. I don't know what the two of you think take the right adrenal out because that's the normal one that's suppressed. Okay, so it's definitely wrong to take out the wrong adrenal. So most of you want to do the correct thing and take out the left adrenal. Okay, fine. And that tells you the answer. So if the ratio is less than 0.5 in the contralateral adrenal compared to the IVC, less than a half, that confirms that you're suppressed. Okay. Now, some centers, I know that ESCS center uses 1, but we use 0.5 to be absolutely sure. And we will discuss the case in the MDT if it's in between. Okay, because There are pros and cons, as he will tell us. So what happened in this case? Well, he had his left adrenal removed, the histology confirmed it, and post-operatively, he was normal, normotensive, no blood pressure tablets, no potassium, very happy. And the question people ask is, did we need the angiogram? And it's obviously there, okay? And that's a good question, which Yasir will talk a bit more about. Now, the really tricky thing is the difficulty cannulating both adrenals, because quite often we don't get into both sides. And if you don't get to both sides, you're missing data. And so the question is, can it be useful? And Yasir will say there are ways to look at it, okay? But I'll just give you the gold standard for exam purposes, which is you will cannulate both. Now, supposing you fail to cannulate the contralateral adrenal, okay? Right adrenal, not cannulated. Now, in centers, we have a lot of what we're going to call high throughput, where the radiologist gets experience, they have a very high success rate. And if you have a center that's only 1 or 2 a year, they have a lower success rate. So one of the GIRFT guidelines is that we try and centralize AVS to people who are good at doing it, okay? So supposing we fail to cannulate the right adrenal gland, okay, then you have this kind of picture. The left side, where the tumor is, 50,000, so same ratio, but the right side, because we're in the IBC basically, and so the cortisol is not high, so you know you're not in, okay, about the same as the IBC, and same with aldosterone, so you have to ignore this side. You know the left side is high, you know the IBC is normal, but you don't know the right is suppressed. You're all voting now for what would you do? And there's your 4 options, and you're voted for repeat the angiogram. Yeah, okay, because we didn't get in. So they say we need to get in there. Now, some of you will still take the left out, which I think is not unreasonable, because we weren't going to do an AVS at all in some centers, okay? Now, when I say to our regulars, can you repeat the angiogram? He says, look, I tried. I know I can't get in. I used the sidewinder catheters. I tried everything. I could not get in. So there's no point in doing that. You need to decide on the strength of what you've got already on these numbers, what to do. Take out the left. And the answer is you can't really, because if the right is not suppressed, you take the left side out, the right will keep on making aldosterone and they won't be cured. Now, of course, it is possible that the right hasn't yet got the disease, and so, as you'll hear later, there's some arguments for doing the operation. It might be bilateral, though. That's the problem. Okay, if you don't count the right, it might be bilateral. So you can remove this adrenal gland and this adenoma, and it might cure the patient for a time. But if it's genetically bilateral disease, then this will take off maybe after 5 years. Now, you could say those are 5 good years of normal retention without potassium. So that's the future, deciding whether or not we should take out bits of adrenal, okay? But that's not part of our current guideline. So we tend to look at the adrenal glands very carefully and say, okay, look, we couldn't get in, and the radiologist will say, look, I can't do it. And then he or she will look at the right adrenal. If it's really smooth and normal, we might think, look, probably it's unilateral. If it's a young patient, it's unilateral. Let's go for it, okay? Now, here's the other situation that might happen. Supposing you fail to cannulate the side with the lesion. The left adrenal is not cannulated because you can't get in. Let's say you can't get around these 2 corners here. This is what we would have seen, okay? So the right side is cannulated, so the cortisol is 2,000, but the left is not, only 400, same as the IVC. So what you then have is a ratio on the IVC of 2.3, and you have got a suppressed axis, right adrenal, but you don't know if the lump you can see on the left side is actually making it. You don't know that, okay? So what would you do? There's your 4 options. Would you like to vote now? 3, 2, 1, and yeah, okay, so this is, I agree with this, right? So with most of you, 47 of you have said left adrenal because the right side is suppressed. So that tells you you don't need to repeat it, okay? This is the one time you don't need to repeat it because you've got the thing that you need. The other side is suppressed. The sublet lesion, therefore, must be the source, and you don't need to prove it with an aldosterone level necessarily. So this is a much better indication for going for a left adrenalectomy than the first case, okay? I know it seems weird, but it's the other side that's the whole point, which is the message of my talk today. So the purpose of cannulation is to prove that the condition is not bilateral and the AC ratio should be less than a half compared to the IBC. Now, I know that Yasser says less than 1. American says less than 1. I think that's fine. I think you need to try your own center and get your own data to decide where to put that cutoff. So in summary, the aim of venous sampling is to prove, that it is not bilateral. Cannulating both adrenals really needs an expert, okay? And so you want to concentrate our experience in centers with a high throughput. If you screen hypertensive patients, you're going to get more bilateral disease, okay? And they should be managed medically. Thank you very much, okay? I will have a little gap now and we'll move on to part 2 shortly. Thank you.